Okay, well, welcome everybody to today's FSHD University webinar. We are the FSHD Society, and for those of you who are not familiar with what we do, we are the world's largest patient-focused and research-driven advocacy organization in the world that is focused solely on FSHD. And we have monthly webinars, usually on the third Thursday of every month at 1:00 p.m. US Eastern Time. And we bring to you experts from the world of FSHD, medical care and research and living. And often we also feature people who have FSHD, because you too are experts in the experience of living with FSHD. So today we have our speaker is Maaike Pelsma, who is a physical therapist at Radboud University Hospital in the Netherlands. Radboud is one of the world's leading centers for FSHD clinical care and clinical research. And we're fortunate to work with many of the clinicians and researchers there. They have done so much to advance this quality of care and our understanding of FSHD. And Maaike is a pediatric physical therapist, if I understand. So this is an area we have never had a chance to really address, which is physical therapy for children in particular, focusing, I think, on the issues with scapular stabilization or the scapular winging, which is one of the earliest manifestations of FSHD. It often shows up in children and can lead to a lot of issues if it's not managed properly. And the good news is that the research is showing there's ways to improve outcomes for children and adults with scapular winging and FSHD. So with that, I would like to turn things over to Maaike.
Well, thank you for your invitation. It's really nice to to be here and that I can go with you by the field within the children with FSHD, and especially with the pediatric physical therapy within those children for the shoulder therapy. So I will share my screen with you. Do you now see the first page of my yes?
Yes,
Okay.
yes, we can see it. Thank you.
Okay. Well, thank you. Well, I'm working, of course, June already told me, at Radboud University Medical Center, and we have like our child hospital, and that's named the Amalia Children's Hospital. And we are also one of the FSHD expertized center together with Leiden, with LUMC. Well, I don't know if you know where the Netherlands lives. It's a really small country up here in Europe, and we really enjoy it to live there. And of course, well, to have not focused only on FSHD, I wanted to tell you about, well, we have like the tulips, of course, you know, and we also have the windmills and a lot of water. And we have like the wooden shoes. And foragers always think that we walk on the wooden shoes, but that wouldn't be so nice for our patients, especially for our FSHD patients. So it's just not true. I wanted to tell you that. And then, of course, we also have our artist, Van Gogh. Maybe you know him. Maybe it's because of my professional eyes, but I always was thinking about him, whether he maybe also had the disease. And well, if I look at his face, then sometimes I see like, okay, I don't see a lot of expression. And then I take a look at his shoulders and I think, okay, they are a little bit lower, especially the right one. So you have a little bit of asymmetric part. I don't know. Maybe he has, but we don't know. I wanted to tell you a little bit about how we work here in the Netherlands. And we have a couple of times in a month, we have like our children's shoulder clinic. So we mainly see their children with shoulder problems, and we see them with our multidisciplinary team, with our pediatricians that are like a neurologist and our rehabilitation doctor. I see them together with my colleague, our physical therapist, and you see him here right under. It's Jos IJsbeert. Maybe you know him. He already performed some presentation up here. And we also have our pediatric occupational therapist and also an occupational therapist who works with adults. And sometimes they work also together to have like more expertise, because also within the adults, we have a lot of expertise within the neuromuscular field and especially also with the shoulder patients. Well, then a patient comes to us and we do an assessment. Sometimes we already know them within our neuromuscular team, but sometimes they just come for the first time. And then when they are specific, they have like a shoulder problem, we see them in our team. We all do our assessments, and then we have an interdisciplinary discussion and also give some advice for their own healthcare professionals, and sometimes within the rehabilitation center, and sometimes they go to just the primary care. And mainly we see children with neuromuscular disorders and shoulder problems. That's actually our focus. But sometimes we also see some orthopedic children, and sometimes they have like already a diagnosis, like which are here, like I'm really confused about the word about speaking it, but neurologic amyotrophy, FSHD, limb girdle muscular dystrophy, and myotone dystrophy, and other nerve disorders. So we see like a lot of people. And well, they're only children, and we see like also some similarities within those patients, because here when you take a look at those three photos, then there's one patient with FSHD, there's one with MD, and one with NA, so the one which I can't speak out. And well, if we take a good look, then we see like in the left side, we really see a asymmetric part. We only see it like scapular winging, and it's only on the right side. That's the NA patient. And in the middle, we see it like both. We see like also some within the deltoid, we see some atrophy, and we see a little bit of asymmetric part. This is the FSHD patient, but you see, of course, the winging, and you see like the scapular is more derotated. And here on the right, you see like the MD patient, the myotonic dystrophy, but you also see like same things, a little bit more similar to the FSHD. So we see some shared characteristics, and we also, of course, we don't do exactly the same within those patients, but we have like an approach who's working with a lot of people. And actually within the NA, we have like also research, which our therapy comes to be, which the therapy is effective. Sorry about my English. If we take a look at the FSHD, like the adults, we see like a lot of scapular instability. We see that mainly, well, almost 97% experience issues with the use of their upper extremities. But a majority of training interventions focused on the lower extremities, which you see here on the right. And you see like those, this picture up here. I don't know. Yeah, here's my mouse. I think you can see it. And you see like here, it's the on this side, it's the change in fat fraction per year. And you see like when you have to use your care, you see it's mainly about, well, 6.5 change in fat fraction per year. So it's getting more fat in the muscle. But when you do exercise, you see that's a little bit, well, not a little bit, it's really mainly the half of it. So it's only for 3% of the fat of the muscles who have a change in fat fraction. So it's pretty good, but that's a training in the lower extremities. And actually, we think that the same is happening in the upper extremities. But we also know from recent research that only 44% is training their upper extremities. So we see a lot of work there to do for us to focus more on the upper extremities. And well, they are pretty busy with trying to make medicines, but still, its training is also a good medicine for FSHD. And then when we focus on the children, we did a natural history study in the Netherlands, the iFocus study, maybe you know it. And there are a lot of outcomes, and here I present only a few of them. And you see like a lot of heterogeneity in this population with facial weakness, like that's for many patients. And we see actually like normal or only mildly affected motor performance. That's measured with the motor function measure. We see hyperlordosis and also a decrease of functional exercise capacity. Also, we see when we do ultrasound, you see like an increased echo intensity on the muscle ultrasonic. Here to the right, you see like a picture, and you see like the more black it is, the more echo intensity it is. So it's more fat or fibrosis what's on the muscles. And you see like the masseter, it's the chewing muscle, is actually normal. It's the same within healthy controls. And all the other muscles which we measured are a little bit less than the normal people. So they have more increased echo intensity. So it's more a fibrosis or a fat. And actually we see that also within the abdominal muscles and in the tight muscles. And we also see sometimes, I'm just losing my mouse here. And also within the trapezius muscle. So they are the shoulder muscles. What we also saw is that a lot of patients do complain about pain, and the pain is on the lower, is on the scapular, a little bit lower than here the neck, around the scapular. I think you recognize that, and on the lower limbs and also on the back, lower back, and we see a lot of fatigue. Mainly 83% reports fatigue. Also, we see a decreased quality of physical well-being. We also performed already a 2 years follow-up. So not all the children, but a lot of the children came back after 2 years, and we measured them again. And then actually we saw that it's slowly progressive. So we thought maybe within the early onset FSHD, we thought maybe we had a little bit more progression, but that wasn't the case, without one exception about the echography. But we have actually an improvement of functional exercise capacity. So we performed the 6 minutes walk test, and they performed a little bit more, a little bit better, but still they had like well, not a large, but it was a difference between the people, between normal, healthy peers and the FSHD patient. They had some increased lumbar hyperlordosis, which is due to the abdominal muscles will become a little bit weaker. And we saw some progressive and on the echo intensity on the muscle ultrasounds. We also saw that it was a little bit more fatigue than they reported 2 years ago, and they also reported like a little bit of more pain, and we saw that at 27% did mention that on the scapular region, and I think we really can do something about it, and I will show you later on two casuistics from that. What we think about what is our hypothesis is that when you have we see a lot about when you see those scapular, you see like they are a little bit winging. We call that, they're not normal, huh? They are really standing a bit like this. And actually sometimes we thought that it's mainly the strength what's the problem. But actually, sometimes we see that the strength is pretty okay and that we can progress and we have like a better stature of the scapular when we focus on the coordination. So then it's not a strength problem, but it's more like a coordination problem. And when we see that, then you have like the dyskinesia. So you can't coordinate your scapular good. Because of that, you have disuse in daily activities. And because of that, because of the disuse, you maybe have some more accelerations of fatty infiltrations. So your muscles will become a little bit fatter. When you have that, you have muscle weakness also. And when you have more muscle weakness, you have more limitations in daily life. And then it can become a visual circle. But maybe when we can train the scapular coordination, maybe because of that, we have less disuse and maybe also less limitations. And maybe because of that, we have slower fatty infiltration. We think about that. We think that it can be true. Of course, it can be true. But we don't have a lot of evidence yet. Of course, I'm a pediatric physical therapist, but which I already told you, we work in a multidisciplinary team, and we also have a multidisciplinary approach. The physical therapy is about moving better your shoulders, but the occupational therapist is really good in conserve energy. When you don't need to have the energy to use your muscles, you have to conserve the energy because then you can move better. So if you're sitting the whole day, or when you're sitting, then it's nice that you have your arm resting on the chair or something else, because if you have to hold your shoulders and you don't rest, then your shoulders are already tired and when you have to move. So we really work together with that, and that's why so that you learn to cope, of course, with the symptoms in daily life, because we don't, it's not that we have the medicine and that it's gonna disappear. If we focus on the shoulder therapy for children, we also focus about regaining motor control of the arm movements. But within an adult, you can really say, okay, it's nice to have your shoulder up there. And when you move like this, then your shoulder comes like that. And you have to do this or that. That's really a way of explicit learning. And actually, within children, it doesn't work that way, especially when they're a little bit younger. Then you really have to focus it and you have to do it on another way. And that's, I will show you some examples about that. What we also saw into our clinical practice is that when we have balance disturbance, we see really an improvement of movement pattern. And we really think that our proprioceptive system, so our sensory system, is a little bit more awake. And then because of that, it's not that your muscles become stronger then, but because of that, you are more awake of your sensory system and you have like a better posture of your scapula. And of course, within children, we have to challenge them. We have to be diverse in our therapy, and it must be fun, because else a child does not want to come anymore. And I think that's really a hassle to do. Of course, we want to have also the transfer to the activities of daily living. And that's also a field of our occupational therapy. To apply it in our activities in daily living. But we do that together, because sometimes when you move your arms a lot of times during the day. And of course you can say, okay, you have to practice 3 times a day, but sometimes that doesn't work because, well, within me the same. If I have to do something or have to have some exercise, it's really a hassle. And then I think, okay, I know that's good for me, but oh, how do I have to do it? So it's nice to have every time, well, like an example to if you pick your glass, then every time you do it on that way, and then you train your shoulders by doing it in activities of daily living. Within occupational therapy, they also learn about conservation energy strategies, effective rostering sitting and lying posture. And sometimes we also use assistive devices. So like arm rest, sorry, like a kinetic way of, well, like, I don't know the English word, that's not good. But like when you have your shoulder, when you have some aids where your shoulder is in, and then the gravity will help you, it will help you against the gravity. And then you still use your muscles, but it's better to use them, even with a little help, than not using them. Here is, I will present you a girl. I have that one. A girl of 9 years old who was diagnosed with FSHD at the age at 7. She has aching pain around the neck and scapular since 6 months, and she has it more on the right side than on the left side. She has ongoing pain, and there are peaks during writing, outdoor playing, walking, and sleeping. And there's an average of 4 paracetamol a day. So that's really a lot of medicine for a young girl. We saw her first on our shoulder clinic, and we saw her together with the occupational therapist. I wanted to first give you some example about the for her movements. I have a film for you where you can see her training like within an implicit way during therapy. And she was also within the primary care, and I often called with the primary care physician, a pediatric physical therapist, and she adapted the therapy at home and at the physical therapy practice. And she often went there, so we had like a transfer because it was like a 1-hour drive to our hospital. So she really had the therapy nearby our home. What you see is when we what we wanted to do is to have more the scapular in a not, well, it's maybe there are also some professionals not within the anterior tilt, the scapular, but a little bit on the posterior tilt, just like a better posture. And we also have like the balance thing together, because then we see that the scapular is more in a good function. And she well, you have to take a good look if you see her moving, but her movements were pretty okay till that time. But she had a lot of complaint about the pain. She had a lot of pain complaints. And here you see that what we wanted to do is to have like a specific muscle, like the muscle of which is called the serratus anterior. And we wanted to have them more, this is in the primary care, and we wanted to have it more active. And we really tried that by doing the movements who are like a little bit backwards with an extra rotated arm and a little bit that way. The movement direction in that way, and then we can stimulate the good way for the scapular to move. And here she is trying to do also the way, but then she also had to make an she has to stand on one leg, and she was able to do that because of course it doesn't have to be a really it doesn't have to, it must not be too hard, but she was okay with that. And then she was drawing a picture on the wall, and then the primary care therapist really she really did some nice things with her, and they were every time they were a little bit different, and it's all focusing about getting the arm more that way, more like activating that specific muscle and the specific way that the scapular is more in the good function. So it's really the implicit way of learning. Here you see the same girl, and it's the first time I saw her. You see on the left picture, and then I saw it within 3 months. I see it's in Dutch here, and then on the right side, it's in 6 months later. And when you take a good look at her scapular, she has more complaints about the right side. You see that here her scapular is a little bit more down rotated. And you also see that that's a little bit of her scapular is a little bit tipping, and it's especially more on the right side. Here you still see it. I think it's not a lot of difference. Of course, it's a little bit another, but it's mainly the same. And within here, after 6 months, I think you see a little bit of difference because I see less tipping. I see a little bit of winging, and I see it also up there. But I see also less down rotated scapular. It's a little bit up rotated, which we want. And if you then take a look at her pain symptoms, because that was the main thing about her, after 3 months, she had a reduction in pain symptoms, especially after therapy and at night. But we continue to do this, and then mainly after 6 months, her pain symptoms were sometimes were they present, but are regular present, but not every day. And they were less during vacation periods, and she woke up at night a few times a week. And after 9 months, we really saw a good transfer. And then she had like only slight pain, slight discomfort. Actually, she didn't call it pain anymore, and she wasn't waking up at night. Well, only once a month. And which was also the case. I think that's also nice to say that she had an adapted chair for school at that time. She had that a couple of months ago. So I think that really also helped with having less pain. And after 9 months, she didn't use any medication before. And before she had 4 medications during a day. And she perceived less local and overall fatigue. So that was also a nice thing for her, and also for her parents. I wanted to present you another boy. He's a bit more affected. He's in the early onset. He has early onset FSHD. He has no pain, but he has a lot of difficulty moving his arms when he came to us. He has certainly loss of strength. Also within his trunk, you can see it. He has a hyperlordosis, and he has loss of coordination as well. Up here you see 2, I wanted to show you. This was when he was 8 years old, and here he was 9 years old. And you can take a look at its scapular function. And I think you know it. I think you also know the trick. If you move faster, then it's getting better. And he's really playing also during treatment and during doing things. And I wanted to show you, this is 1 year later. And when you see him moving, it's he has more hyperlordosis. He has more difficulties with walking. And with his scapular function, he also has a little bit more difficulties. And that's actually, well, we did the shoulder training within him as well. And I wanted to show you also what we did. Here you see a movement of that. We also had to do the implicit way. So what we're trying to do is really to have the scapular a bit rotated the good way, like the upper way. And we can we try to do that within the combination of the extra, actually the same thing, but here we have to adapt it a bit because he cannot do the thing like the other girl did. And but we really wanted to have, like, there was also a basket where he could throw to. And here you also see him playing basketball. And actually what I was thinking about when he has like when he has the movement like in the front, I'm not you can think about that. Okay, we don't want that to stimulate it, but what you see is that his scapular go like this, and I think that's also because he has some counter power, because he's holding his hands together. But what he's doing, and that I really like more, is doing it the other way around. So backwards, so throwing it backwards. And then he is really focusing on that way. And I really enjoy that, because then his scapular even is rotating more upwards. And then the right muscles are doing it. So this is, we don't do it that you have to do it like 20 times or 8 times, because it's not a strength training. It's more like a coordination training. And here he doesn't even know that he's training. He's just having fun. And he also played tennis. And tennis we also enjoy, particularly when we use the backhands. And here he's playing with his dad. And here he has, because at his own place, he has like a less, a racket with less weight. So we had to hold it with two hands together, but he was able to do it. And then we really enjoy like the backhand movements, because then you also have like the good movements. And when we think about, which I showed you before, that all exercise, they're also good. We think about moving the upper arm. So if you have a little bit different arm movements, then it's not a problem. And within this boy, he after 1 year, he still had no pain. He had a slowly progression of difficulties moving his arms. And he was but he had fun during the therapy. And yeah, well, what can we say? Is that a positive effect or not? You don't know if it was more progressive if we didn't do it. So that's actually, of course, you have to do some research because of that. But I think we also take a look at the principle, which we use a lot in neuromuscular disease, that the no use is disuse. When you don't use your arms, then they become more fatty. And when you use them, then we can try to have the function as good as possible. So what we see within our shoulder therapy within FSHD, we see an improvement or a stable scapular balance, or within this boy, we saw a little bit of progression, but maybe, yeah, I can't say it in actually. We have a reduced pain within that girl, and we have some other children who has that as well. We see that they use decreased energy expenditure during movements and daytime. And we see, like within that girl, we see like a stable muscle weakness. So it is a bit weaker, but we see that it's stabilized. But we don't know if we have like if this is the way of our therapy. And that's why we're doing also some research. So we're performing right now, well, we're gonna perform a pilot study, and it's gonna start for typically within these children to have like, if we can see, okay, if we do it like several months, then what's the outcome, and then more on a research way. So you are already at home, I guess, but if I have some take-home messages, then I wouldn't say that a strength issue isn't the same as a coordination problem. And the coordination is trainable. And within children, we see that the implicit way of training is favorable. Sometimes when we have like a child like 16 years old, we use the combination of the two. And a multidisciplinary approach is really really favorable. This was my what I wanted to talk to you. And of course, you can contact me if you want, and I have here my contact details.
Thank you so much. That's great. let's see, we can, if you can maybe unshare, and then we can just have a little question
Yes.
and answer time. So in the audience, if you have questions, then please put them in the Q&A section. We're going to be monitoring that. And we do have a question posed there. This is from Darla. She says, my older son, he had the scapular fixation surgery while in high school. But now in his 20s, he has a lot of pain. Is there anything we can do for pain relief? Of course, hard to say without examining him, but what are possible causes of pain in someone who has had the scapular fixation, and what would you advise?
Yeah, well, that's really I think that's, you really have to take a look at where the pain is and when the pain is there. So if it's only within movements, or okay, sorry, I saw the other two. If it's only within is it during the day, during sitting? Maybe if you can also have some, I don't know if you have some sitting aids, or a chair who is really for him only. And I think within us, I would say we have to first look and take a look, where are the complaints, and when, and then we have to try some solutions. But maybe the occupational therapist is really also a solution if he didn't had it anymore, didn't already had it.
Yeah. Actually, in one of our other Zoom meetings, there's a patient who shared that she uses an ergonomic armrest. So it's attaches to the edge of her desk or table, and it supports her arm. And she said that made a huge difference. It took away all this pain that she was having in her shoulders. And I wonder if you could comment on that, because I think many patients don't know about supporting your arm in this way. And you mentioned it a little bit.
Yeah, the arm support. Yeah, we really enjoy it when they are a little bit weaker. Within the children, we sometimes, well, that this boy, he's also he's he would he's now getting it arm rest support, well, arm support, and then it's what has the weight is, it's less. I think that's really a nice way of having less pain, because their static posture is really it really costs a lot of energy only to sit. And if you really, because the girl, which we also saw, the girl is really, when she's resting, when she had her own chair, then the pain really went away. I think that's a lot of the posture during sitting, but also during lying in the night. That the night is really a way to rest, and then resting with some pillows and with having your arms in a good position, that it's just a little horizontal. That's really good. Yeah.
Thank you. There's a question whether she has a 13-year-old son whose right side is affected. She was wondering about a shoulder brace during the day. I'm not sure if she's referring to maybe a brace to hold in the scapula to try to stabilize scapula, or some other kind of brace maybe. But
yes, sometimes when we well, it depends on what kind of brace it is. But sometimes when you're not in the position to have your arm rest the whole day, then sometimes a shoulder brace of that it lifts a little bit the weight of your upper arm, then sometimes that's really okay to having not a lot of pain. But sometimes it's really it's also more difficult to move your arm. So what mainly we advise, when you don't have to use it, when you're at home and you can sit like in a good way, then don't use it that much. But it really depends on what kind of brace it is, actually. Yes.
okay. Yeah. Oh, she's clarified. She said it's for stabilizing the scapula. So it's probably a type of brace that's exerting pressure on the scapula.
Yeah, that can be, well, within children, we don't use that a lot, but it can be, when you stabilize it, you have like more, you use a little bit, well, you help the muscles maybe a little bit, but sometimes you can't use your compensatory strategy anymore, so you have to take a good look at that. But if it helps on having less fatigue or less pain, I think you should focus on that. And if it's gonna move for your situation better, then you can try to do you can use it. It's not like it's we don't like it. It's you have to take a look at if it's working.
We have two people with questions about sleeping positions, which you also mentioned. They both seem to experience pain from when lying down. What's the best way to have that evaluated and solved?
Well, actually, the best way to lay down is on your back. That's the best way. And then it's good that your arms, when you're on your supine, then your shoulder must be, your upper arm must be horizontal. And mainly when you don't use a small cushion, then it's a little bit less lower. Then your elbow is a little bit lower than your shoulder. So it's good to have like a thin cushion, which is under your upper arm. So your upper arm is stayed horizontal. And then you can have it on both sides, of course. Prone, when you live on when you have a prone lying position, sorry for my English as well, then it's more difficult to have like the good posture. So we de-advise that posture to sleep in. But when you can lay pretty good on your side, like side lying, but then just lay a little bit back, lean a little bit backwards. So it's like 1/3 of side lying and a little bit more on your back. And then the underwards scapular your underwards arm actually and scapular has to be a little bit in front. And then the upward scapular has to, the other arm was on the above side, has to be on a cushion as well. And your back also has to be a cushion on your back. So then you're laying a little bit, well, I can't do it right, I can't perform it right now, but then you're laying not like this, but a little bit like that. And then up here, you have your arm is more that way. And then here you have a cushion on your back, but also on your arm. So your upper arm must be horizontal as well.
Wow.
I don't know if I tell
I
you
think, you know what, I'm thinking we need to have a whole nother webinar on sleeping, on sleeping positions.
Well,
We've
we
never
have
even thought about that.
Yeah, our occupational therapists really give good advices. Yeah.
That's great.
So maybe you can
Yes, I will ask you. I'll follow up with
ask
you.
them.
You have give me
Yeah.
your name. Let's see. Well, this might be a little, I don't know if you can answer this question, but someone asked, because right now we're in the vaccination season and people are worried about whether the vaccine can irritate or even damage muscle and someone with FSHD. Have you heard anything about that in terms of what's the best?
I'm sorry. No, I would
No, okay.
I would ask this to our doctor. I don't know. I'm sorry. No.
Yeah, okay.
I can't give an advice about that.
Actually, a person saying vaccinations commonly using bicep. I don't think so. I've never gotten a vaccination bicep.
Mainly
It's usually
in the deltoids.
Yeah, it's a deltoid,
And
which
sometimes
is
sometimes, well, you can ask if it can be just under the skin, and that it's not like intramuscular vaccination, but sometimes it depends on the vaccination, of course. I don't know if there's any evidence about that it's damaging it.
Mhm.
Actually, the children within our hospital, they use like the vaccination of our healthcare system, and well, we don't give a specific advice for them.
Mhm. But I think you have a good point. The vaccination's usually given in the deltoid, and the research shows the deltoid is usually not affected in FSHD. So yeah, that's good. Okay.
Yes.
So everybody likes the idea of a webinar on sleeping position, and
That's nice.
and someone asked if the recording will be available. We will be reviewing and editing the recording, and hopefully have a version we can share with you on our YouTube channel at some point. So yes. So yeah, we don't have any other questions today. So thank you so much. I hope, can you make your slides
Yes.
available to us? Okay, we
Yes.
can post that
Yes.
on our website. So
Yes.
thank you so much. Oh, actually, I had a quick question and then we'll wrap up. You mentioned implicit and explicit learning, and I'm not sure if everybody understands the difference. So maybe you
Yeah.
can define what is explicit versus implicit learning.
Yes. Yes, of course. Like when you have like explicit learning, then you really explicit what the patient should do. So you really explicit, okay, you have to have your shoulder not like this, but you have it a little bit like that, and then you have to move your arm in that direction, and you have to do that a couple of times. So it's really, okay, bend your elbow a little bit more, or do a little bit more that, or just really have some explicit instructions, a lot of verbal instructions for doing the exercise. And the implicit way of learning is actually like every child is learning how to walk. You don't say a child how to walk, because he just is going to walk, and that's actually a bit well, it's a little bit different, because that's also walking is like a way you're already, it's the best way to move around. But it's actually when just doing the good exercises, then on the implicit way, you're training the good muscles to function and to have like a better coordination.
Okay. So in a way, it's learning by actually doing it correctly, as opposed to intellectually describing it and then trying to follow it. Okay, that makes sense.
Yeah.
Okay. Well, thank you so much. That was such an informative webinar, and we hope we can have you back again sometime. And we will work on getting a webinar together about sleeping position.
Yeah,
that really opened my eyes. And so thank you, everybody, for joining us. Join us next month for our webinar. It's on Thursday, the third Thursday of the month at 1 p.m. And it will be with Michaela Walker, who is the sort of project manager for the MOVE and MOVE Plus studies. These are two major natural history studies that are going on, and they especially are trying to recruit more children and more non-ambulatory individuals in that study, because these are two populations within FSHD that we don't have a lot of natural history data. You mentioned the study in the Netherlands. We need more studies, more longitudinal studies, and it's very important for many reasons, including if these individuals are ever to be included in future clinical trials. The natural history data is the essential foundation on which you design clinical trials. So join us next month to learn more about that. Okay, thank you. We'll see you again. Bye-bye.